Our next speaker is our colleague, Dr. Susan Hariri, from the Centers for Disease Control. Susan's going to talk about HPV vaccine coverage and monitoring in low and middle income countries and share with us some of her experience with that process also here in the U.S.
Thanks, Francisco. So now for something completely different, I'm going to talk about, as he said, vaccine monitoring, vaccine coverage monitoring, with the focus on low and middle income countries. Okay, so as you've heard in the last couple of days, monitoring and evaluation is a very important component of vaccine introduction, any vaccine introduction. And one piece of that is monitoring coverage of vaccine to evaluate the vaccination program and the delivery strategy, but also to monitor uptake in the target population and to monitor trends over time. Now, we know that HPV vaccine has a set of unique challenges that apply also to monitoring coverage. As you heard in several talks today and yesterday, HPV vaccines are recommended to be given in 3 doses over a 6-month period, and the primary target population for vaccination are girls between the ages of 9 and 13 years. So in November of 2009, WHO held a consensus meeting to discuss specifically HPV vaccine monitoring. And this included coverage, safety, and impact. I'm not going to go over the impact or the safety. I'm focusing on coverage today. And so the consensus on coverage monitoring was that in order to monitor the impact of HPV vaccine, we need coverage by age and by dose. So we need a little more information than traditionally is collected for vaccine coverage monitoring. In particular, we need the date of birth of the girl, the date of the vaccination, the dose number for every dose administered. And then it was agreed at that meeting that a good summary indicator for monitoring trends over time is to look at the proportion of girls that are vaccinated with the complete series by age 15 years. Which is now 3 doses. And for that, of course, you need a denominator, which is the total number of girls that are eligible that are in the target population. So, and it was agreed that new approaches are needed for a variety of things. Now, the surveys are one way, as you know, to monitor coverage. I'm not going to, again, discuss that. I'm going to focus today on use of administrative data, and so there are new approaches to registering the girls for the HPV vaccine doses and also for recording the HPV vaccine doses in an adolescent health card that needs to be retained throughout the girl's lifetime. Oh, thank you. Thanks. So as I said, registering HPV vaccine doses requires collecting information on date of birth, date of vaccination, and dose number. And so there are multiple records generated at different administrative levels, and these need to be coordinated. And there are a number of challenges to registering this information, one being that birth dates aren't always available everywhere, and also that there's more than one age cohort, especially where school-based vaccination is used as a delivery strategy. There could be more than one age cohort, which could complicate record keeping a little bit more. And then there are different delivery strategies that are applied in the same community, and over time they could change. So again, that makes it hard to keep good records. And so we need to have some way to keep consistent records and to consolidate data from the different delivery venues and the different administrative levels. Now, as far as individual health records, this is something that is done for childhood vaccinations. It's a health record that's maintained by the parent. In this case, our target population are adolescent girls, and so they need to be responsible for retaining this health or immunization card for their lifetime. And so there's been a lot of discussion around this, as Natalie talked about earlier, making this broader to include, to have a health card that's actually includes a lot of different adolescent health issues. So it would be an adolescent health record that would also include HPV vaccination. The challenge to that is that, you know, we don't really know if there's going to be good retention in this age group. So there are a number of tools and guidances that are being developed by WHO and other organizations. Specifically, there's a WHO document that's being in draft form right now. It's called the HPV Vaccine Coverage Monitoring Tool, which is a comprehensive guidance on the data collection process for monitoring HPV vaccine coverage, and it's intended for healthcare providers and managers and officers involved in HPV vaccine efforts. And so it gives very detailed instructions on how to monitor by age and by dose at the different levels. And it also instructs on how to calculate estimates and summary indicators. And as I say, it's not finalized, but it is available in draft form if countries are interested in piloting it. So these are just images from the monitoring tool. This is a flow chart that shows you the information that needs to be collected and the forms that are available for collecting the information at each of the different administrative levels. There's 3 administrative levels here, but depending on the country and the structure, it could be more than that. There could be intermediary steps. And so the first thing in registering a girl is to have a provider logbook or a provider register. And this is an example that's in the coverage monitoring tool. So as you can see, it needs to be very granular, the name of the girl, the address, the date of birth, and then the age of the girl for every dose that's administered. And so this is done at the vaccination session, either by the vaccine provider or the assistant. And you know, if the date of birth is not known, you know, the parent can report the age, or the girl can report the age. In the worst case scenario, if they don't know the age, the vaccine provider should make an educated guess, so don't leave it blank. And then those provider logbooks are used to complete this daily tally sheet at the end of each vaccination day. The vaccine provider at the service delivery level, somebody will take those logbooks and then make a tick mark for every girl on this tally sheet that was vaccinated and then sum it up. And this tally sheet is something that the immunization programs are very familiar with. It's a little bit different because it's by age and by dose. And then on a monthly basis, again at the service delivery level, the tally sheets are used to sum up the number of girls that were vaccinated by age and by dose for every vaccination day in that month. And this is reported to the next administrative level, in this case the district level. And at that level then, a summary report is generated using the data from the report sheet at the district level. And then the final product is this form, which is the annual summary report. This can be done at the district level and at the national levels. And so as you can see in the, I don't know if I can use this, on the left side of this form, you have the total number of girls by age and by dose that were vaccinated. And then in the middle, you have the estimated size of the target population, and with that, then you can calculate the coverage rates for each age cohort by dose. And this is really important information because this is exactly what's required on the WHO-UNICEF joint reporting form, which is a requirement for countries to report vaccination. And this is what it looks like for HPV vaccination. It was introduced in 2011, so the first year of data that's going to be available from this joint reporting form is for 2010. So now I'm going to switch and talk and just kind of walk you through an example. As you know, Rwanda is one of the only African countries that have introduced HPV vaccine nationally as part of a comprehensive cervical cancer control initiative in the country. And they used this WHO HPV vaccine coverage monitoring tool and modified it for use for their coverage monitoring. Okay, so the vaccine introduction plan was largely developed by the Rwanda Ministry of Health with assistance from multiple regional and global partners. There was a technical advisory group that consisted of multiple disciplines that was established, including various groups from the Ministry of Health, the Ministry of Education, local clinicians and community leaders. And then the subcommittees were assigned to different tasks, one of which was to develop the data collection and other monitoring tools. So just to give you a quick background, what the delivery strategy, the primary delivery strategy that was selected in Rwanda was school-based. And their target population was girls 11 to 15 years, with priority to 11 and 12-year-old girls the first year. This was this was a Merck donation program for 3 years, and so the first year was girls 11 and 12 years of age were prioritized, and so the target grade that these girls were thought to be in is primary 6, and so that was the grade that was selected for vaccination that year. And I think you heard this morning about the critical role of political leadership and support, and this picture shows you this was the launch of the HPV vaccination in Rwanda, and that's the First Lady of Rwanda who participated. There was very strong government support. That was actually one of the strengths of this program. And girls who were absent from school and who were not enrolled in school were followed up by community health workers and brought into the health centers for vaccination. Okay, so this is kind of a summary of all the different data collection tools. You can't really see it very well, but basically on the left side it lists the specific tool, and then across the top it has the purpose and intent for use, what health system level it is to be used at, the person that is responsible for completing it, the timing of the completion, location of completion, and then location where it will be stored. So this is the personal HPV vaccination card that was developed in Rwanda for HPV vaccine. So as you can see, it collects very detailed information, including the date of birth, the mother and father's name, the name of the school in which the girl is vaccinated, and then all the different administrative levels associated with that school. And then on the right-hand side, you have date vaccinated for each dose, and then on the card, there's a reminder for the next vaccination date so that the girl remembers to come back for doses 2 and 3. This is the provider logbook. Again, it's almost identical to what I showed you from the WHO monitoring tool. The only thing that changed here is that they chose to collect mother and father name instead of address for the girl because they thought it would be an easier way to find the girls if needed. And this is the daily tally sheet. Again, it's almost identical to what I showed you previously. Here what they changed was the ages. They decided to include a category for 15 to 20-year-olds and then those who are older than 21, whereas on the WHO form it just goes up to 15 and then unknown age. And they also decided to collect some additional information that helps with the programmatic aspects of implementation at the bottom of this tally sheet. So here's a form that Rwanda actually decided to create. This is not in the monitoring tool, and this is because they primarily use a school-based vaccination program. This is an absentee list that's supposed to be maintained at the school or at the health center, and it does not indicate the dose number, so I'm assuming that they would have to refer to the logbook or the register to determine which dose this absentee girl missed. So just to go over the results, the first dose was administered nationwide in April of 2011. As I said, schools were the primary vaccination centers, and there were about 6 or 7 schools that each health center was responsible for. There were about 95,000 girls estimated to be vaccinated in grades primary 6. And the results were aggregated at the district level and at the national level. At the district level, there were 40 health districts, and then at the national level by age. So these are some results that have been presented by Rwanda at various meetings. And this is by district. This is the percent coverage by district. And this is the first 20 health districts. And you can see that this is for the first dose. They achieved very high coverage in almost all districts. This is the last 20 districts in Rwanda, and again, it's pretty much over 90% across the board for the first dose in the first year. And then this is the aggregate data at the national level by age, and interestingly, you see that there's actually over 100% coverage, which is not really possible, and so it's probably because they didn't have a very good denominator, or they estimated the denominator. And so this is by age from 9, 10, 11, 12, 13, 14, and then 15 plus. And then overall, they had almost 100% coverage. So this graph shows you the coverage by girls who were in school versus girls who were out of school. And so of the 94,000 or so girls that were enrolled in school, about 97% of them were reported to have completed the first dose, whereas in the girls who were not in school, about 3,600 estimated, only 43% of them were vaccinated for the first dose. One thing that was really interesting is, as I said, the priority ages in the first year were ages 11 and 12, but what happened was the girls who were vaccinated, who were in grade P6, were primarily 15 and older. And so, the proportion of girls that were in the priority age range was just a little over 10%. So they ended up vaccinating a lot of older girls. So in summary, HPV vaccine coverage monitoring is needed to evaluate vaccine program and delivery strategy, to determine coverage in the population recommended for vaccination, and to compare coverage rates over time and across geographic regions. There are unique challenges to monitoring HPV vaccine coverage, including the fact that this is recommended as a 3-dose vaccine over a 6-month period. Target population includes a range of ages rather than a single age cohort. And it's targeted to adolescent girls, and so the different delivery strategies and combination of strategies need to be used to access this population. So we need new approaches for monitoring coverage by age and by dose in order to monitor coverage over time, including date of birth, date of vaccine administration, and dose number. And then to have some sort of a health record for the girl to maintain over her lifetime. And as I said, there are a number of coverage monitoring tools that are being developed by WHO and others, and they are available through WHO for countries that want to pilot them. Thank you.